Hello, Dr. David McFadden here from the Dental Implant Center in Dallas, Texas. Today's topic is the history and evolution of implant bridges. We get a lot of questions about these on the YouTube channel and through our website, so I wanted to go through my history of implant bridges and how I've evolved and how the technique has evolved over the past 28 or so years. And here's the picture of the office on a nice summer day. Before we get into the details, I just want to make the comments that 28 or 30 years ago, we really only had the option of implant bridges. It was the norm for people who were missing or soon to be missing all their teeth. We didn't have all-on-4. We did have overdenture options where the dentures snapped onto the implants, but most people didn't want that option because of the stigma of anything removable. What exactly are the benefits of implant bridges, and why am I always talking about them and so passionate about them? First, they look like natural teeth. Second, they feel like natural teeth. Third, they function like natural teeth. And fourth, they clean like a bridge on natural teeth. We can teach our patients how to keep these prostheses clean, and we rarely ever have to take them out. Why is it the obvious choice in implant dentistry? Because we've got a 100-year or more track record with crowns and bridges on natural teeth. Here's an example of an upper jaw on a patient with crowns on all 14 of his teeth. My goal has been and will be to try to mimic this with our implant bridges. Nothing looks better, nothing is easier to clean. Our dental oath, as much like the medical oath that medical doctors take, is first and foremost, do no harm. I would also mention that our dental goal from day one, year one as dental students, is that we should always preserve natural tissue. Whenever possible, we're trying to save tooth structure if we're doing a simple filling. We're trying to do an ideal crown preparation so we're not removing too much tooth structure. And in implant dentistry, it should be no different. We should try to preserve patients' natural tissues whenever possible. So let me jump off my soapbox for a second and go back to what the title of this presentation is. My history and the evolution of implant bridges. In 1988, when I first got started in dentistry, the implant industry was mixing teeth and implants. So as far back as 35 years, we are combining teeth with implants in the same jaw. Here's an example of that. This patient had bad root canals and cavities on her lower back teeth. So we were able to do one implant for each crown and give her 8 implants with 8 individual crowns. This is what I mean by mixing teeth and implants. This goes further back than 1988 actually. Here's the clinical picture of that patient with the 8 implants and the 8 implant crowns. Looking in the mouth, nobody would be able to tell that these 4 teeth and these 4 teeth were even on implants. They should look just like the teeth that should be there, whether it's a crown on a tooth or a crown on an implant. Seeing that last picture and realizing that those were implant crowns on implants and not natural teeth or not crowns on teeth, it begs the question, why not attempt to do the same for patients with all implants? I think it's an obvious answer, and that is that we should absolutely try to give the patient back what they had, or even better than what they had when their teeth were in their healthiest condition. So in 1995, I actually did my first implant bridge. It wasn't revolutionary at the time. It was just my attempt to give the patient back something better than they had, and maybe something better than they ever had. Here is that very patient. As you can see, it may not be readily obvious, but as you can see, his teeth are not in great shape. He's got moderate to severe periodontal disease, which means he has a genetic predisposition for the bad bacteria in the mouth to proliferate over the good bacteria. This causes inflammation, bone loss, and tooth mobility. And here is that very patient after extractions, multiple implants, and implant bridges. Here is the x-ray of that patient. You can see we put a lot of implants in. 30 years ago, we were still not completely convinced that implants were a long-term solution, and we figured the more the merrier. If a couple implants failed with a person with this many implants, the treatment could still be salvaged. But I've learned that too many implants is also a problem, and I'll address that later. So for 15 years, from 1995 to around 2010, I just kept doing the same thing, trying to do better for each new patient, trying to learn from the treatments that I had done in the past, and just kept doing implant bridges. Here's another patient from that 15-year time frame where she came in with a lot of missing upper back teeth. Her front teeth were in relatively good shape, but she was of the ilk that teeth had failed her by the age of 40. So she was done with her teeth. She wanted to do implants that could not decay and would never need a root canal, because those were the two reasons she kept losing teeth. She would get cavities, get root canals, the tooth would break, and ultimately need to be extracted. So this is another example of an implant bridge preoperative picture. And here she is after multiple extractions, multiple implants, and her implant bridge. Many times patients ask me if I would consider doing individual bridges or one continuous bridge of 12 or 14 units. And I've gone back and forth on that topic throughout my career. There's reasons to do separate bridges and there's reasons not to. And that's beyond the scope of what we're going to talk about. But I will summarize the answer by simply saying I'm more inclined to do one continuous bridge now than individual bridges. And here is her x-ray. As you can see, she got 8 upper implants and has 12 units of bridge work on them. Many patients can postpone treatment in one arch to make the financial commitment lower by doing just the arch that's the most urgent. And that was the case for this patient, where she did her upper arch somewhere around 2005 to 2008 and waited until 2022 to do her lower arch. Her lower teeth were in better shape than her uppers, but just like her uppers, they eventually failed her and became more problematic than she wanted to keep up with. So here's a picture in between treatment. We were still able to use her lower left implants that were placed in 2005 and simply remove other teeth, place additional implants, and make her a lower bridge. Here is her lower implant bridge, all one piece. And you'll notice a little bit of artistic creativity. She did not want perfect teeth, and she asked if we could do a setup or make the bridge in a way that looked more natural. So she went with something less than polar white, which I'm always a fan of, but she wanted her lower front teeth to be a little bit uneven, and that's what we gave her, and she loves the outcome. Here is her final result. The uppers were done in 2005, the lowers were done in 2022. And again, I would say, like I said in the beginning, consider these uppers are now, in 2023, they are now 18 years old. They look phenomenal. No changes in the bone, no changes in the tissue. I expect the same for the lower. And this is her final x-ray. In and around 2010, I switched from cemented implant bridges to screw-retained implant bridges. Why did I do that? It's more expensive to do screw-retained implant bridges than cement, but what we found out was the cement we use for cementing crowns and bridges on teeth or implants is toxic to the soft tissues. But we didn't see any of the negative effects of the cement for anywhere between 6 and 10 years. So it took a long time for us to understand that the cement used 6 to 10 years ago was actually causing inflammation and bone loss, and in some cases, implant failure. So one big innovation that took place in and around 2010 is that practitioners who care about long-term outcomes, we all use screw retention now for all of our implant restorations. So there's a little micro screw that holds the bridge to the implant, keeps it secure, and that avoids the use of any cement that is toxic to the tissues. Just about that same time, the all-on-4 protocol, or the all-on-4 technique that you've heard me talk about in half my videos, it was introduced to the United States. It was developed in Portugal in a very large dental clinic in Lisbon, and it was designed for people who were missing teeth for many, many years. It was actually a pretty good protocol for patients who had very little bone from the ravages of tooth loss over a 10 to 30 year period. So that's where it started. Then it migrated into the US, and it also became more and more popular for people with existing teeth. As you've heard me say, and as you've seen in my prior videos, this is a reasonably good outcome for all-on-4. Why did the outcome turn out like this? It turned out like this because the protocol for all-on-4 is to remove massive amounts of bone to make room for these huge prostheses. I call them dentures on stilts. Once you disrupt the natural bony contour that the patient had around their teeth, you're going to cause ongoing resorption. It will happen for anywhere between 6 and 18 months, and it results in outcomes like this. Sometimes the doctor covers the implants with a prosthesis after they become exposed like this, but unfortunately that only makes the cleansability problem more difficult. And another example of an all-on-4 case, I didn't do these cases, but they come to my office trying to get a solution. They realize something went horribly wrong. They're not exactly sure what. But in this case, the rush to give patients teeth on the same day caused a lot of problems. So the implants are at the wrong angle. They're in the wrong position. They are outside the keratinized tissue, which is the good firm tissue that keeps implants healthy. So the prosthesis is then fabricated, and this only exacerbates the problem with cleansability, tissue loss, bone loss, and in this case even infection. I don't want to harp on all-on-4. If you've watched any of my other videos, you know all of the complaints I have against all-on-4. So let's go forward with history and evolution of implant bridges. So from 2010 until 2023, I want to share with you some of the techniques I've developed, ways that we preserve tissue even better than we did back in the 1990s, and some of my protocol. You can only become good at something if you're constantly questioning your outcomes. I do that almost to a fault. It's almost psychosis, I think, at times, but I'm always thinking about what is best for the long-term success. These treatments are so expensive. They have to last as long as possible and hopefully even a lifetime. So that's first on my list of questions. What can I do to give the patient the very best chance for long-term success? I know this sounds obvious, but I ask myself, and have ever since All-on-4 was developed, what would I want in my own mouth? Assuming that dentists could have anything they wanted, our friends would do the treatment for us. Let's take cost out of it. What would I want in my own mouth? Well, of course, I'd want something that looks, feels, functions, and cleans like natural teeth. It's a no-brainer, right? And again, I hope this doesn't sound egregious on my part, but I take so many pictures, over 2 million pictures of my work over the last 35 years. How can I learn and how can I improve from every patient treatment? Well, you scrutinize your outcomes. It's quite simple. I look at the treatment that I rendered on large 27-inch monitors and I pick it apart. Every case that we finish, I go over it in detail at the end. So I start with the pictures of the patient before treatment, I look at the patient's pictures during treatment, and I look at the ones afterwards. And every single time, every slide, every picture I'm looking at, I'm thinking to myself, could I have done that better in some way? And I think this is unique in all fields. I don't care whether you're an electrician or you're a plumber or you're a brain surgeon. I think we should all be trying to get better on a daily basis. So I guess that kind of also begs the question, why are quality outcomes so important to me? And I've done soul searching. I've pondered this for years. Why I'm such a stickler, or why I'm so obsessed about quality outcomes. I often wonder, maybe my parents instilled this in me, and I think in many ways they did. I've always been super competitive, whether it been sports or at a red light in a car or in dentistry. I've always wanted to be the best me that I can be, which I guess implies that I want to be better than my colleagues. I do lecture a lot, and I mentioned the 2 million plus pictures I've taken over the years. I want to be able to show my dental audiences treatment that wows them, that blows them away, that inspires them to try to do better. And maybe it's just as simple as I want to do the right thing for my patients. And I've concluded that implant bridges are the right thing for those patients who want their mouth restored with dental implants. I alluded to this quote a couple slides ago. We can all be better than we are. I heard this quote in somewhere in the 1980s when I was coaching swimming. I was a competitive swimmer through college and ended up coaching swimming while I was in dental school. And I absolutely loved the job. Best job I ever had, I think. But I used to try to encourage and motivate my swimmers with these motivational quotes. And I came across this one way back then, and I just loved it. So this is another part, I guess, of anybody who excels at anything. I think you have to have this passion or this burning desire to be better today than you were yesterday, and try to be better tomorrow than you are today. So I want to share with you what I've learned over the last 28 years in the form of a summary. First, preserving natural bone and gum tissue are absolutely what's best for the patient. I didn't really talk about this, but I'll mention it now, and that is the difference between convex and concave contours of your final restoration. Every all-on-4 is concave by its nature, and I reject that. Concavities cannot be cleaned in the mouth with brushing, flossing, or water picking. So the top of the prosthesis where it meets the gum tissues, or if it's the lower arch, the bottom of the prosthesis where it meets the gum tissues, has to be convex, rounded so that the patient can clean it with brushing, flossing, and water picking. Screw retention instead of cement is the most tissue friendly. This is not an opinion, this is fact based on research. Anybody still doing cemented restorations in 2023 is at least 10 years behind the curve. The use of fixed temporary bridges preserves the soft tissues. I'm going to show you some examples of that later in the presentation, but part of this I've developed over just the past 5 years, and that is if the patient comes in with teeth and good gum tissues, meaning the little triangular piece of tissue between the teeth called the papilla is still intact, my goal is to preserve that throughout treatment so that it can frame the beautiful teeth at the end. In the previous slide, I said that we can maintain papilla if the patient has teeth and the papilla when they come in. But what I failed to mention, for patients who are missing teeth, sections of teeth, or all the teeth in one arch, by not removing bone and not removing tissue, we can sometimes regenerate some or most of that papilla that is missing. And the way we do that is we shape our temporary bridge at the time of surgery to direct the healing for that particular patient. So like in this picture, all of our contours are convex, like I talk about in many of my videos. And this is what allows us to help with the healing of the tissues from the day of surgery onward. Here's another example of a temporary that was made for a patient on the day of surgery. This person had some existing implants, and we put in additional implants. So in the places where we are missing teeth and missing implants, we're shaping these temporaries with a convex shape so that those actually go into the sockets or into the gums of a patient who doesn't have existing teeth. Because the surgical site will heal to whatever contour we make with a temporary, we can direct the healing. So it takes patience, time, and energy to make these temporaries serve that purpose. Here's an example of that same temporary being placed on a patient at the time of surgery. You can see there's bleeding here, and the gums were open or the sockets are open. So what we have to do in the fabrication process of the temporary is extend the plastic temporary up into that socket so that it directs the healing. It maintains the papilla or regenerates the papilla. But this is how the magic actually happens. More is not always better. I showed you the picture of my very first implant bridge patient from the mid-1990s, and his implants, I think he had 18 implants. If they're perfectly placed, and we try to do that every time, you can use more implants. But many times if there are too many implants, the space between them is inadequate and we can't preserve that tissue that I just mentioned on the previous slide. These are some of the cases that I inherit after implants have been placed and all-on-4 has been attempted. And what you see here is an indiscriminate placement of dental implants. I don't know whether the patient was being charged by the number of implants or not, but there are implants that are just not necessary here. This implant definitely was unnecessary. This one was probably unnecessary. This one, unnecessary. And again, I call it uninspired, if not lazy, implant surgery. The place that this patient actually needs those two implants on the upper are here and here. And on the lower, there's bone here, why not use it? There's bone here, why not use it? So I don't usually take implants out because it's very destructive to the bone around that implant. But because I'm willing to take the CBCT scan, find out where the bone is, and do a careful, precise surgery, I'm able to actually place implants where they are biomechanically important, or what I call strategic. You can have all the implants that you can possibly place in the front of the mouth, but that doesn't support the bridge in the back of the mouth. So careful, strategic, precise implant placement is what we should all be striving for. Here's that same patient after I added those 4 implants that I was mentioning. We placed an implant, 2 implants in the front on the upper, so that this span would not be so long for the zirconium. And even though zirconium is strong, we like to minimize the number of places where it's unsupported. I only like to have 2 teeth span the gap between 2 implants. Here it would have been at least 4. On the lower, we would have had to cantilever off of the back implant by 2 teeth this way and 2 teeth this way. But by taking my time and placing 2 additional implants, the patient now has a more traditional bridge where there's nothing extended from the last implant that can break. This is a case of mine from a few years ago, and what I'd like to point out here is that the implants are placed strategically based on biomechanics. We have 1 tooth that's spanning a gap between implants here, 2 teeth here, 2 here, and 1 here. And on the bottom, we actually only have 2 teeth here to here. We have 4 teeth here to here, and 3 teeth here. So on the lower, since I did this surgery, I would now come back at this same first surgery. I would place an additional implant here, an additional implant here. So my protocol is constantly evolving based on what I learn about the engineering and the biomechanics of zirconium. So strategic implant placement is what the doctors should be striving for. More is not better in many cases. And I've said this before in my videos. Every dentist on planet Earth would choose implant bridges if it was their own mouth. This makes a few small assumptions: that the patient has good bone and tissue to start with. But even within the absence of good bone and soft tissue, this protocol that I've developed with convex interfaces, with more implants, with parallel implants, every dentist on planet Earth would want this in their own mouth. So it begs the question, why are 99% of patients in the world today getting All-on-4? I'll leave the answer to you. I think you know the answer. So let's go through a few cases here to demonstrate what I expect in an outcome in 2023. Here's a patient who, like many others, has been losing teeth throughout their adult life, who has gum problems, bone problems, and missing tooth problems. What I want you to see and understand, though, is that we have, even though her teeth aren't pretty, we still have this sculpting. These pink pieces of tissue are called papilla. Now, with the All-on-4 protocol, not only is the doctor going to cut those away, he or she is going to cut the bone back to right about here to make room for that denture on stilts. So if you've got bone and tissue, even though it's not perfect, why not try to save it? It seems obvious to me. Here is that patient's final result. I will comment on the lower. She had massive bone loss from gum disease in the lower. So in patients that already have bone loss, I can't put that bone back. So she does have a fairly large prosthesis in the lower, but it is like a bridge. It's not like a denture on stilts. So let's go to the upper, and I'll outline these papilla that we were able to maintain throughout treatment. Not only maintain them, but I would argue that we've made these tissues better. We did not remove bone or gum tissue, and now it frames her teeth perfectly. I know my viewers like to see teeth, but these pictures excite me more than anything, including teeth, and that is that we have been able to maintain this beautiful, perfect gingival architecture. Because we placed an appropriate number of implants, these should maintain themselves long term, just like the patients I showed you back from the 1990s and early 2000s. With the right number of implants and the right tissue-gum interface, this should be a long-term success. And here you can see fewer implants. She only had a few places where we could place implants due to her bone loss, but 6 uppers and 4 lowers, she should be good for many, many years, if not decades to come. Here's another patient, and this patient flew in from Northern California to receive implant bridges. And her husband and I joked that they probably flew over 50,000 dentists to get to Dallas to get this kind of treatment. And it's sad. It's a sad testimonial about my industry that this is possible, yet there's only a handful of us doing it. So as you can see here, much like all of our implant full mouth patients, she's got missing teeth, decayed teeth, broken teeth, but she's got good gum tissue and good bone. So we're going to preserve that. Here is her outcome. Much like the others, we've maintained the gum tissue. It now frames the teeth like it should, and she didn't have massive bone loss anywhere, so we were able to give her implant bridges that look, feel, function, and clean like natural teeth in both arches. And here's her final outcome. She has 5 upper and 5 lower implants. I would have liked to have more upper implants on her upper left side, but she wasn't able to have those due to her sinus proximity. And you'll also notice that there are some teeth, there are some roots still here. This is another part of a technique that I've developed over just the past 18 to 24 months, and that is if a tooth has a successful root canal, I've started leaving the roots in the bone so that the bone doesn't resorb, and that's a process. When you take a tooth out, the socket is going to collapse by as much as 50%. If we leave these successful root canal roots in the bone, that doesn't happen. So this is probably my most recent innovation, along with finding a material that fills the socket and keeps it from collapsing, the most recent innovations that I've come up with. And again, another patient with broken teeth, missing teeth, cavities, who's just done with spending tens of thousands of dollars every few years on his teeth. And here's his final result. One of the very best cases I've done. You'll notice we preserved all of his tissue, didn't remove one speck of bone. He's got implant bridges in both arches, both of which are zirconium. And his final panoramic x-ray, you'll notice that he has more implants than the last 2 patients. He actually had quite a few implants when he arrived for his first visit. These 3 were existing, these 2 were existing, this one was existing, and this one was existing. Many offices, especially the all-on-4 offices, tell you that they can't use existing implants. They're going to take them out at the time of surgery. Again, the only reason that that's true is because the implants, usually like this gentleman's implants, were placed for crowns or bridges. They get in the way of the bone removal for the all-on-4 technique, so they won't use them. But I would say that in well over half the cases of patients who come with existing implants, we use them. I mean, again, it seems obvious. If they're there, they're successful for many, many years, why not incorporate them in the final restoration? And that's what we do whenever we can. You may have seen this patient in my gallery on the website, but it's an interesting case. The patient is a severe dental phobic, almost manic when he presents for care, and he asked his previous dentist to patch and repair wherever possible. So as you can see here, his upper arch is almost one continuous patch. This isn't healthy for the gums. The tooth on the upper right, the lateral incisor here keeps coming unbonded. So he's finally at the point where he's ready to fix his mouth, and he was referred here for that, and we offered him implant bridges, and he elected to do them. We could only get him to do his upper arch at this time, but this is what it turned out like. And again, he had surprisingly harder bone than you would expect. He had bone in the back of his mouth, which the vast majority of patients do. The all-on-4 technique does not utilize that bone in the back of the mouth. So we do and have great success doing so. But talk about a change in appearance. And here's his final panoramic x-ray. We used 7 upper implants, and we made one 12-unit bridge to go on those 7 implants. Looks, feels, functions, and cleans like natural teeth. And this is a great time for me to point out convex versus concave. You'll notice that all of our contours are convex. They interface with the gums in a positive way, as opposed to concave, which is more like a saddle. It fits over the gums like a saddle. This is cleansable, concave is not. And that's the final case I wanted to show you. And in conclusion, I just want to say that I hope I've answered all of the questions that I posed at the beginning and throughout this presentation. How implant bridges got started. They were the norm until 2010. That's what everybody would want, including all the dentists on the planet. And I hope you understand some of the refinements and the nuances of the protocol that I've developed over the years to try to give patients these amazing outcomes. Thank you for listening.